Okay, thank you for that introduction and welcome everyone here this evening. And I'd like to thank Kelly for her wonderful welcome to country and acknowledge the traditional owners of the land in which this event is taking place, the land of the Wurundjeri, and pay respect to elders past and present. So, I know that we have got a few things to report to you this evening, and I'd like to share those with you. And just for those of you who are new to the land of Medicare Locals, we'll have a little bit of brief information about what they are. You know, that Medicare Locals are not-for-profit, regionally based organisations, and they really are focusing around the... down a bit, yep. They're focused around trying to work to improve the health of the population that lives within the catchment area of the Medicare Local. There's 61 across the country, across Australia, and this is the region that the Northern Melbourne Medicare Local covers. So you can see the local government areas up there that we cover, and it's only part of Hume, so that Hume's kind of been cut in half by the boundaries of federal versus state. It's the other interesting thing is boundaries never really match up, and they've done it again with Medicare Locals. So the idea of Medicare Locals is to support greater linkages between and coordination of primary healthcare services across the region, working really closely between primary care, general practitioners, community health services, allied health and the hospital networks, and trying to do things that will sew those bits of the healthcare system together. Another big task for Medicare Locals is to identify gaps in primary healthcare services in particular, and to identify gaps in the way that we might do things better, particularly around areas of great need. We're also charged with developing really effective collaborations, and I'm going to be telling you some of those this evening, so that just giving you an update as to what we're doing. The Northern Melbourne Medicare Local is going to focus on a few areas to begin with. You can't do everything at once, that's very obvious when things begin. And so 4 key areas we're focusing on at present are enhancing access to after-hours services, that's been a very big focus for Medicare Locals. Continuing to provide better access to the primary mental health care services that were previously run through the divisions of general practice, and facilitating better access to aged care services for primary care for people in aged care, and supporting the uptake of e-health. These are all sort of really important new things that are happening as well. Now, there's a lot of people in the Northern Melbourne Medicare Local region, and this estimate is 679,067. So it's more than 500,000 people, and the whole idea of the Medicare Local is that it's going to be doing things that's going to be providing better primary care services for all of those people in that catchment. Now, we know that not everybody gets all of their healthcare from healthcare services within the catchment, and they'll go to other places outside of our catchment, but they'll be also looked after by other Medicare Locals. So the Medicare Locals cover the entire geographical region. But how you can see here that if you think about it for a moment, that we've got a very diverse community. We've got affluent areas with stable populations. We've got areas of socioeconomic disadvantage, pockets of recently arrived refugees, population pockets in the southern section with people aged over 65 years that's expected to double within the next decade or so. So that's a huge growth area of ageing population. Then up in the north, we've got some of the fastest growing local government areas in the land. Culturally diverse, recently arrived refugees, a large Indigenous population, and many young families moving into the area. Now, the predictions at how quickly this population is going to grow is very alarming, that over the next decade another 250,000 people will move into that northern section of the Medicare Local, so a third, another added to the population just in that northern area. And I don't think we can really imagine the kind of healthcare services that we might need to put in place if we're going to meet that demand properly. Austin's asked you to fill out some forms about 2017, so you can put your thoughts to it. But it's a really big challenge. Now, we've got many opportunities to work together with you to improve health. So where do we start? Well, one of the things that we do is look at health priorities, and this is just a little snapshot of some conditions that we have around diabetes complications. And it's interesting to think of today, 22 people admitted to the health services, Northern or Austin, with health complications of diabetes, and that adds up to almost 67,000 bed days in any 1 year, that the average person stays 8 days. And if we want to look at dental conditions, another thing that, I must say, when I saw this, I was surprised. I thought, dental conditions? Really? Causing people to be admitted to hospital? 16,000 bed days, and 4 people will have been admitted today because of dental problems. It's quite amazing. Kidney disease is the other, really, I suppose it's the next diabetes, I think of it. We're all about diabetes for years and years and years, and now kidney disease is starting to enter into the really public awareness. And kidney disease, because in large part of all the diabetes, kidney disease is going to become a huge impost on the health service. And already we have 65,000 days of hospital admission per year. So these are big figures. Now, these conditions are up because they're what's called ambulatory care sensitive conditions. They're avoidable. If we can reorganise primary care, we should be able to reduce the number of people getting admitted. So those 30 people or so that have been admitted to hospital today don't need to be there. So how do we find out in our healthcare services why they're there? Why are they there? And what can our health services do differently in primary care so they don't end up there? That's the challenge of the Medicare Local. It's not an easy one to solve, and it's one that has to be solved by working with general practitioners, community health, and all the allied health people involved in diabetes care, for example. And that's what it's about. So there's lots of people to communicate with, and just taking a look at the general practices in the region, these are the numbers by local government area. And say in Hume there's about 137 GPs working at best estimate, Whittlesea 124, Nillumbik 71, Banyule 131, Darebin 134. Now, the area that's going to grow enormously up there at the top of Hume and Whittlesea, the Whittlesea Growth Corridor, at the moment only 45 practices. At the moment only 124 GPs. It's going to have to be a huge change in workforce to meet the demands that are coming there. So this is just, our vision really is, as I said, better health outcomes for people living in the region. Our values are really important to state, I think, because the Medicare Local is a new initiative. It's been formed from what was previously divisions of general practice, and it's the model was put forward to the government in this area was to be a commissioning model. Not all Medicare Locals are commissioning. Some of them have really just grown out of the divisions of general practice, but commissioning ones are also a common model. And the thing about being a commissioning model is that you have to have very good, transparent processes to commission work, and obviously strategic and collaborative ways to do so, and that really do meet the needs of the community. And that's what the board has been working very hard at, getting in place things that are transparent and really good processes. Ultimately, we want to make sure that people such as this, and these are all photos taken in our local community, that they receive care in the right place at the right time. This is the organisational chart of the Medicare Local, and I'm going to embarrass everybody by introducing them and getting you to be able to see them if you haven't met them before. So, Michelle Thompson is our CEO, so Michelle you've seen, but you can give a wave. So that Anne-Marie Zauer, who is the Director of Development and Integration, so welcome to Anne-Marie. John Walker, who's Director of Communications and Engagement down the back. I'd like to thank John for his assistance in getting the presentation together and organising tonight. Angela Caruso, who's the Development and Integration Manager for Darebin. So if anyone from Darebin area, make sure you introduce yourself if you haven't met Angela. Paul Canham, who's the Development and Integration Manager for Banyule. Imran Mansour, who's the Development Integration Manager for Whittlesea. Narelle Quinn, who is Development and Integration Manager of Special Projects, and Amanda Smith, who's Development and Integration Manager for Hume. Andrew Morrison, the VIP, leads the Aboriginal Health Program, who has got the special introduction. Thanks, Andrew. And Diane Strauss, who's the Executive Assistant and Office Coordinator. Okay. So that's the staff of the Medicare Local. There's also obviously things that we engage with others to deliver, and in particular it's Infinity Health Solutions that... is people here from Infinity this evening? Do you want to stand up too? Stephanie and Glenda. So welcome to you as well. So we're going to go on. And so they've, and I'll explain a bit more about that in a moment. So, moving ahead. So the three other things that we've got up there. The Strategic Advisory Committee has recently been established, and it's going to be chaired by Gabrielle McTurnan. And the Strategic Advisory Committee brings together a number of community primary care providers to provide guidance and leadership on directions of the Medicare Local to the board, and we're looking forward to working with that group. The Healthy Kids Check is an initiative that was introduced in 2008 for children aged 3 to 5 to ensure they're healthy, fit and ready for school. And it's currently being expanded to look at the emotional wellbeing of children as well. And this is a pilot project that's being funded through the Medicare Local Alliance. And currently the Medicare Local's working with 6 general practitioners, practice nurses and Aboriginal health workers to pilot this new approach. And the training's going to commence this month. The other thing we're looking at the moment, a very important feasibility study is going to start soon about looking for a new dental model, private-public partnership to try and meet the needs of people that aren't getting adequate dental care and trying to reduce those bed days that I showed you previously. That's underway. We're continuing to provide the ATAPs, which is the access to psychological services that everyone who's involved in psychology will be very familiar with. And Infinity Health Solutions have been contracted for the delivery of the ATAPs within our Medicare Local boundaries, and that's just continued seamlessly from what was being provided by divisions of general practice prior to the Medicare Local gaining responsibility in July. The Known Gap Communication Project is looking at improving consumer decision making about medical services after hours, access to that. And we're going to be looking at working on that communications project. Another thing we're doing around child health is the Vulnerable Children Cycle of Care project, and this one is once again a bit of a development opportunity to strengthen the continuity of primary health care and case management for children in out-of-home, or what was previously called foster care, on the edge of care in the Medicare Local catchments. And this clinical pathway is being managed by the Medicare Local in conjunction with other groups from GPV as well. Okay, so what else are we doing? Almost there. So the other things we're doing is obviously one of the big focuses of divisions of general practice was providing support to general practices for things around chronic disease management, computer support and things such as that. And this has continued under the Medicare Local scheme across the country, and it's very important for us to meet the health objectives that we've set. Infinity Health Solutions can actually delivering that support across the Medicare Local district, and that's going very well. And at the moment, the Infinity staff and the Medicare Local development and integration managers are going around that area, visiting all the general practices and explaining how the service will operate. We've got a problem also with cancer screening and risk assessment in our region, and one of the things that the Medicare Local's been doing is going to be taking advantage of a new primary care cancer professor at the University of Melbourne that's starting next year to get advice about getting risk assessment and family history questionnaires at the point of contact, and that will be part of, for the Medicare Local will be a part of testing that out as well. Upskilling locum GPs through education and training. We know that general practice in particular relies a lot on locum GPs, and they're very important for general practices to keep going. And there'll be 2 training programs for locums delivering after-hours services. One in particular around improving cultural competency, that's been an area that's been noted to have difficulties, and the other around delivering palliative care during after-hours services. So 2 very important areas around cultural competency and after-hour and palliative care. Now, these are being done in conjunction with Inner Northwest Melbourne Medicare Local and Inner East Melbourne Medicare Local. So we'll also be partnering with the obvious people to do things as well. We've got lots going around after hours, primary care and population health planning project. Once again, we're working with our partners at Inner Northwest Melbourne Medicare Local and the Department of Health Northwest Metropolitan Region. The project's testing whether data categories regarding after-hours care can be integrated into population health planning. And we're focusing on what's known as the triage category 4 and 5, emergency department presentations, for any of you from the hospitals. And we're working with Northern, Austin, St Vincent's and Royal Melbourne to look at this as a really whole of catchment area. So that's a really big project. Closing the gap is very important. Our Medicare Local has one of the largest Indigenous communities in Melbourne, and we've just completed a needs assessment for the catchment, identifying the greatest primary needs of the Aboriginal community. A number of activities have been commenced and will be such as working with Pharmacy Guild to improve access to closing the gap prescriptions. And Andrew Watson, who's here this evening, I'm sure will be very pleased to speak to you about the other things that are happening there. The Residential Aged Care Facilities Outreach Project is an after-hours pilot of 12 months, working in collaboration with Austin and Northern Health. The project's going to look at an enhanced model of service for residential aged care facilities after-hours emergency presentations. So once again, a very important area. We've also got a big problem with not having after-hours services available to everybody across the catchment. And we have, in particular, areas such as Arthurs Creek, Christmas Hills, Nutfield, Smiths Gully, St Andrews, Wattle Glen, Beveridge, Bruce's Creek, goes on. There's quite a list of places. And to address this issue, we recently put out a tender looking at extending services, and we are currently in negotiations with the preferred provider to provide those services to people that have never had access to after-hours general practice services. Now, nearly there. So, at the request of the Department of Health and Ageing, we were asked to review some of the aspects of our constitution, and that was not an uncommon thing for Medicare locals to be asked to do. The Department of Health and Ageing have put as part of Medicare Local funding, an absolutely essential component is that every Medicare Local has a skills-based board, and that the Medicare Locals have good processes in place for ensuring continuity of knowledge across board transitions, etc. And looking at developing skills matrices to appoint board members. So the board's been working hard on that, and we have made the necessary changes to the constitution, and we'll be taking that to members this week. We will be having an annual general meeting, and we hope that all of you will attend. It'll be in November, later in the year, on the 29th of November. We'll be advertising an expression of interest in a couple of weeks' time to fill vacancies on the board. So we'll let you know how that, you'll see more from us. So we would really welcome you to become a member of the Medicare Local. Their membership forms are on our website, and please do download them, and if you've got any questions, get in contact with Medicare Local staff. We'd really like to hear your ideas for solving some of the problems that we face across the catchment in terms of primary healthcare delivery to the population of these local government areas, and we need to work with you to solve these problems, otherwise we won't get anywhere at all. I'd like to thank Michelle and her team for all the hard work that they've been doing. I think for those of you who were at our last networking event, I'm sure you will see that things have been really busy in the meantime. and lots of programs are underway, but there's many more things that will be happening over the coming months. I'd like to thank you for attending and hand back to Michelle.